Hello, welcome back to Top Med Talk. I'm Andy Cumpstey and I'm your host and managing editor of Top Med Talk, and I'm joined by my co-host, Kate Leslie.
Hi, Andy.
And as before, we're back at Anesthesiology 2025. That's the annual scientific meeting for the American Society of Anesthesiologists at this fantastic venue here in San Antonio. And again, the ASA have been fantastic, giving us some really brilliant space and also some fantastic guests. And without further ado, I'm going to ask Dr. Samer Narouze to introduce himself for us.
Sure. Thank you very much for having me here. I'm enjoying the ASA 2025 very much so far. Let me introduce myself. My name is Samer Narouze. I'm the chair of the pain committee for the ASA. So I represent the ASA for the newly formed Pain Medicine Coalition, among other pain organizations. I'm the past president for the American Society of Regional Anesthesia and Pain Medicine, and also a professor of anesthesiology at Case Western Reserve University.
Brilliant.
Thanks for having me.
Well, let's dive straight in. So you mentioned about the Pain Medicine Coalition.
Yeah.
So for those listeners who may not be based in America, what is it and what's its priorities and why did it come into existence?
Sure. This is like, if you look at it as a transformative effort to help the pain medicine community in general. So it's an alliance, strategic alliance between the American Society of Anesthesia and the other prestigious pain medicine organizations in the area. Namely the American Society of Regional Anesthesia and Pain Medicine, which is a devoted society for the whole spectrum of pain, from preoperative, acute, postoperative, chronic pain, and rehabilitation. And also we are having ties, strong ties now with the American Academy of Physical Medicine and Rehab. They have different skill sets that they bring to the table, very prestigious society. And the fourth organization is the Interventional Pain Spine Society, which is the focus society from the PM&R physician in chronic pain, MSTK, and spine rehabilitation. So this alliance between those four strong organizations, we believe that this will transform the field and we will be the #1 advocate for pain medicine, physicians as well as patients.
Around the world, patients have trouble accessing specialist pain medicine physicians, and I presume that's the same in the United States. Is one of the priorities of the coalition to work with government or insurers and hospitals to get better access to pain medicine?
It's good that you mentioned this because actually this is the top priority for this newly formed alliance. Patient access, definitely, because there's too many barriers for patient access to appropriate pain care. First is the lack of qualified pain physician, board-certified pain physician trained in the multidisciplinary approach. So this is the first barrier. The second barrier is the insurance barrier. The lack of coverage for some of the non-opioid modalities of treatment. As much as we want to avoid overuse of opioid prescriptions, we want, on the other hand, to make non-opioid treatment therapies available, whether pharmacological or interventions. There is lots of requirement from third-party payers and the CMS, like prior authorization, denials. You have to try ABC first before you move into this. So we are working through legislative effort, through advocacy policymakers to remove those burdens and obstacles and layers of bureaucracy that prevent access for the poor pain patient to the appropriate treatment. Before it's too late and the patient is crippled from pain, and then we worry about how we rehabilitate the patient and make them a functioning citizen in the community.
Have you worked at all on gathering data to support these advocacy efforts, like the health economics of not treating pain or the distress and loss of work associated with pain? Or is that already well enough established in the United States?
It is well known, but it doesn't hurt to do more education, widespread. Maybe it's more known in the healthcare community, among physicians and patients. They know that in USA we have millions of patients suffering from chronic pain. But when it comes to advocate at the level of legislators, we emphasize on what's published by the International Institute of Medicine about this exact numbers that you mentioned. The big impact, economical impact and societal impact from chronic pain, because it's a long-lasting disease. It's life-changing can be. So it's always better to prevent chronic acute pain from developing into chronic pain rather than managing the challenge of rehabilitating patient with chronic pain. So we have data now to support that appropriate management of acute pain would eventually prevent patients from having chronic pain. On the other hand, early intervention of chronic pain will prevent disability and loss of function, loss of work hours. So all this will be translated to a dollar value that help our cause. But there is barriers also, meaning that coverage, the most innovative pain procedure, which usually the most effective in challenging cases, are expensive. So we have to weigh the balance. So we are doing like working with some guidelines, clinical guidelines, to support evidence-based, which patient will benefit from which intervention.
Yeah.
And how, when you're working with those guidelines as an example, but perhaps other work as well as advocating for the patients, I mean, presumably you're advocating for the pain specialists as well, and that must be quite an interesting balance, I guess, but you're working on both sides?
Absolutely. We are advocates for the pain community, patients and the healthcare clinicians, pain physicians. So access to patient care, but also reimbursement issue and coverage for the procedure and the pain physician, because it's quite frustrating for both ends that your hands are tied. You are limited by the options that you give to your patient. Someone else is making decisions for you. So the ASA, through its legislative effort, working on the federal level, on the CMS level, on the AMA level, on state levels, to support legislation that will make non-opioid treatment available, like the Alternative to Pain Act. We are a big supporter of it. This should prevent prior authorization, should prevent out or limit out-of-pocket money for non-opioids, basically making non-opioid therapies as easy and as accessible as opioid prescription. You can go, you can leave the office with an opioid prescription. We should make it easier to have access to other treatment options the same way. Honestly, what we are trying to establish here is to like rebrand the pain medicine field. It's like really a transformative effort to change the image that it's either opioids or it's a specialty that focus only on interventions. No, the pain medicine will be a deep specialty that covers the whole aspect of pain in a truly multimodal approach, deeply rooted in neuroscience, evidence-based medicine, patient-centric care that support each step of the therapy. So we are kind of not just rebranding, but re-establishing the integrity in the field, that this will support not only physicians that we represent, but we are also the #1 advocate for pain patients.
So the members of the American Society of Anesthesiologists are supporting this effort through their membership subscriptions. Is the ASA supporting or encouraging other types of contributions to this new system?
It's, to my understanding, it's the first year of it. So it's supported by the 4 organizations. ASA is the major, is the mother, is the flagship for this organization now, because it's a huge membership and the well-established infrastructure, the reputation. The American Academy of PMR also is many thousand patients. Between the 4 societies, we are representing almost 70,000 physicians, pain physicians.
Wow.
So the 4 societies are supporting it initially purely from their resources, which is basically membership. What will happen in the next, it depends on what's involvement and how the project will progress. We would expect more support, but we're taking step by step.
Before we started chatting, Andy, Sam was telling us about the compassion and kindness that he thinks he brings and that others bring to the working with patients with pain, appreciating their distress and so forth. And it was a lovely conversation, Sam. You clearly enjoy your work as a pain physician.
100%. If I have to choose it again, I would choose pain physician because you make a difference. And pain is an experience. It's not just you feel the pain or something is painful. It's the way you react to feel, the experience that comes with the pain. So we have to understand the whole picture of chronic pain, the psychosocial economics of pain. It's not just you need to remove the cause of the pain. You need to treat the consequences that this pain left behind. Depression, anxiety, isolation. So that's why I'm saying we are rebranding it. It's not just medicine to treat one aspect or an injection to block this nerve. No, this is one piece out of the whole picture. We need to treat the whole patient to make again the patient functioning and forgetting this bad experience with pain, not just removing the cause of pain. Removing the cause of pain is number one in the step, but you have to treat the consequences that happened from years and years of pain. So that's why it feels great that when you see the patient coming back with family members, I have my family back, I was able to go to this wedding, able to travel, attend the graduation of my grandson. This is priceless, seriously.
Totally.
Yeah. Well, it sounds like a fantastic coalition, really, hopefully will be very impactful to patients very soon. Hopefully you'll be able to come back and tell us very soon about some of the things that the coalition's gone on to achieve.
Would love to.
Could you maybe give our listeners some things they should be looking out for in the coming future that you're going to be tackling soon, or things that we might hopefully see on the horizon when you come back next time that have been objectives of the coalition to come?
Yes, we are working with the other organizations on restoring the integrity of pain based on evidence-based. We're supporting between the 4 societies. There are multi-society clinical guidelines addressing different pain disorders. This will be published soon in the next couple of years. We have a long track history of coming with those guidelines. Third-party payer, they are looking for stuff like this to support the literature. Actually, we are the advisors for the most of those third-party payers when it comes to questions about coverage for procedures, evidence-based behind procedure. They always consult the ASA and through the pain community to give us our input and advice and suggestions. So we are working on this to establish a strong evidence-based component. To build on it, why we need to get quick approval for X, Y, and Z, or those non-opioid prescription. They are without the side effects of opioid. Those procedures, if it applied early on, it will prevent the deleterious effects of chronic pain for years. So this is one aspect. The other thing, we are working also to have solid definition of the scope of practice. We need well-established 360 pain physician who went through rigorous residency, fellowship training, obtained certifications. And actually, this past month, we just announced the birth of a new certificate. We call Certificate of Innovation and Leadership in Pain Medicine. So this is even after you do all of this, you graduated from the pain fellowship, we equip you how to survive in the real world. Practice management, healthcare policy, education, new innovation techniques, mentorship program. So guarantee a smooth transition from being trainee and just finished fellowship to be an effective, functioning, efficient physician, pain physician in the community.
That's interesting.
So this is usually what we hear back from the graduating resident fellows, that they are not equipped enough. They still need mentorship. They need tools for them to survive, and how to do prior authorization, how to do peer-to-peer review, how to build a case for the patients, how to be a good advocate in their institution, their community, in their state level. So we will be equipping them. The first pilot group, 20 physicians, the top graduating pain fellows were hand-selected to sit for this certificate. It's a program for the whole year.
Right, so it's a 12-month
so this will be the, yes. Yeah. So this will be the start, and then we'll get the feedback from them to enrich this program more and see what are the gaps that we need to fulfill.
And that's running in multiple states, or in?
Yes, it's a whole North America, actually.
Fantastic. And so when does that start? You say starts soon?
Actually, we had the first meeting 2 weeks ago. It's supposed to start mid-November.
Excellent.
Yeah. So we'll have an input about it, feedback next year.
Fantastic.
In ASA 2026.
Well, thank you so much, Sam. It's been wonderful to have you on the podcast.
Thank you.
Thanks, Andy, for co-hosting once again. Fantastic.
Sure.
And thank you to you out in the exhibition hall for watching us doing our podcast. We'd like to thank the ASA again for their hospitality, GE Healthcare and BD Advanced Patient Monitoring for their ongoing support. Please go to topmedtalk.com and subscribe and listen to all our podcasts, or you can see us all on all our other social media channels. So thank you, Andy, and cheers.
Thanks, Kate. See you soon.
Thank you.